right, thanks so much. I think I'm kicking off the rapid section of this, so I guess buckle in because I think the speaking is about to get a lot faster. So just jumping right into my presentation. So we've heard over the last couple days how reinfection following DA therapy is really one of the major concerns around scale-up of hepatitis C DA treatment in people who inject drugs. And despite some of the data we've seen in settings that have scaled up treatment, there do remain some questions about scaling up, about reinfection in those settings. And so we aim to, first of all, assess the incidence of hepatitis C reinfection and investigate predictors of time to hepatitis C reinfection in the SHARP-C study, which was a prospective observational cohort study investigating reinfection following successful DAA treatment and it enrolled between 2018 and 2022 across 14 sites in 3 countries. And it was majority of patients were recruited through drug and alcohol clinics, and all patients needed to have reported injecting drug use within the last 6 months at enrollment. So to be included in the study, participants recruited into sort of 2 groups. The first was those before initiating treatment, and they were treated as part of the study, and as well as those who had a previous recorded SVR. And so the rate of reinfection was calculated using person time at risk of reinfection, and factors associated with reinfection were assessed using Cox proportional hazard models. Now I won't go through all this, but just to say we had 112 people who contributed follow-up time, and so 100% of the population had injected in the last 6 months, but of these, 86% had actually injected in the last month. So obviously this is a relatively high-risk group in terms of being at risk of reinfection. So these are the 11 cases of reinfection that we saw in the study. A couple things to point out. So all of the people who were reinfected were recruited in that prior to commencing DAA treatment group. And I think this is somewhat reflected in the sort of the estimated time to reinfection that we saw, where a lot of the reinfections occurred quite rapidly, and I think the majority were within this first 6 months. And so there might be a little bit of a higher risk period in the time immediately after treatment, and so that might be why we didn't see any reinfections in that group who were recruited after having an SVR, because they may have already gone through that time period. And also just to say, 100% of the 11 cases of reinfection had reported injecting drug use during follow-up, and more than half had reported daily or greater injecting during follow-up, at least once. So overall, we saw a reinfection incidence of 9.7 cases per 100 person years, over 114 person years of follow-up. When we did the Cox proportional hazard analysis, we didn't see any significant factors associated with reinfection, but that I do want to remind you that 100% of the reinfection cases had injected drugs and were in that enrolled before treatment group, so that was 100% predictive, so it obviously couldn't be included in this model. Just to point out, non-significant, but there was an elevated rate of reinfection in the younger group at 13.8 cases per 100 person years. In those who injected in the last month during treatment or during follow-up, the incidence was 11.1 cases. And in that enrolled before treatment group, it was 15.9 cases per 100 person years. And then we finally looked at just among people who injected drugs in the last month during the study. And again, no significant factors, but there was a elevated incidence of reinfection in people who reported injecting and sharing, which I think is unsurprising, at 24.3 cases per 100 person years. So just to tie things up, we obviously saw a relatively high rate of reinfection in this study, with all reinfections occurring among those with ongoing injecting, and with relatively short time to reinfection in these patients. And so what I think this really highlights is the need to focus on this post-treatment period, focus on enhancing harm reduction, but also to focus on ensuring people are getting retested for reinfection to ensure that they can be retreated rapidly. And just like to quickly thank the SHARP-C study participants and everyone who contributed to this study, and thank you.
Well done to keep it to 5 minutes. We maybe can take one question. Does anyone have anything? So we'll have the one over there. And then just for our wonderful IT person, if these presentations are 5 minutes, if we could set the clock to 5 minutes each.
So thank you. This is amazing. I love more reinfection data all the time. And for your study and for Christian's presentation, I think so much about the potential benefits of network-based, like large-scale cohorted Hep C treatment together to try to reduce this reinfection risk. And I'm just curious if, I don't know if you've thought about that or if you've thought about looking at how to mitigate that risk for folks going forward.
You mean in terms of how to mitigate the risk of reinfection after treatment?
Yes, yeah.
Yeah, so I think one of the main things is obviously when we look and we see that the people who continue to share after treatment are at obviously a substantial greater risk, there is obviously some gaps. And this is in settings with a lot of access to harm reduction because we were recruiting through drug and alcohol clinics. So there is obviously the need for more education, more access to needle and syringe programs and OAT services for these patients who are starting on treatment. I think it's a really good opportunity to sort of engage patients in that process.
Thanks, Evan.
Thank you.
Move on. Well done.